Good morning, everybody. So I'm so pleased to welcome all of you to our panel discussion on the Gary and Mary West Senior Dental Center. It really is a truly innovative model that delivers holistic approaches to integrating dental, health, and wellness to improve seniors' health. I would like to thank those that are joining in the room, as well as those that are joining on the live stream. Feel free to submit questions online via our interactive session and follow us at West Health on Twitter. My name is Tim Lash, and I have the honor of serving as the Chief Strategy Officer at West Health and also the President of the Gary and Mary West Policy Center. Our new dental center in San Diego is first of its kind, and it's one that is truly needed. It provides low-income seniors with access to affordable, high-quality oral health care that's integrated with comprehensive education, clinical, and wellness services. It's been in operation for the past year and is a result of a 3-year journey by our founders, Gary and Mary West. Today, we're here to discuss the learnings to date, the challenges we've faced along the way, and our plans moving forward. We're also here to learn from you all. Help us to better understand how we can improve the quality of the services we're offering and enhance oral health care to seniors nationally. Gary and Mary are pioneering philanthropists and visionaries who have made successful aging their legacy. Their passion and dedication to our nation's seniors is an inspiration to us all. West Health was created through their generosity and their vision. Our singular mission is enabling seniors to successfully age in place with the health and support services that preserve and protect their dignity, their quality of life, and their independence. Something that we know is truly important, and it's really only when you start to consider those three facets and the holistic individual and the context in which they experience aging that we can hope to have successful outcomes. Too many people in our growing senior population are forced to choose among such basic needs as food, medicine, and housing, and have difficulty navigating a complex healthcare system that's not readily accessible to them. And I think many in this room know that oral health care has historically taken a back seat, and it's been that way for far too long, despite evidence that bad teeth and gums are linked to malnutrition, heart disease, breast cancer, cognitive decline, diabetes, and even stroke. In fact, in a recent JAMA article, there was a study that featured findings that suggest that oral bacteria may be linked to some cases of rheumatoid arthritis. Yet, another, link and consideration, and really proof that we need to think holistically about the needs and health to include the oral health care of our nation's seniors. The need is significantly greater for low-income seniors who typically lack access to affordable oral health care and are often forced to live in pain or lose their teeth altogether. It's something that I think many of us have experienced firsthand, and it's something that Gary and Mary have experienced firsthand. As regular volunteers at the Senior Wellness Center they established 7 years ago in downtown San Diego, they noticed that seniors were covering their mouths in shame due to lack of teeth. They couldn't eat the healthy meals or chew their food, and it was affecting, not surprisingly, their overall health. Gary and Mary knew they had to take action, and through $2 million in grants from their foundation, the West created a unique community dental center that provides oral health care to seniors lacking the ability to pay. They've made it affordable and accessible to hundreds of older adults in San Diego that come to the Senior Wellness Center every day. And the location is absolutely key, as it provides the opportunity, as you'll hear during the panel, to bring together the care where the seniors are, and it enables a seamless integration of oral health care with a suite of nutrition, case management, and wellness services. Additionally, we're studying the outcomes here, and we're evolving the models so that we can coordinate care and that other communities, healthcare providers, and policymakers can benefit from the work that we're doing. So I'm so pleased to be joined with 4 additional panelists here, and the goal of today is really to explore, I think, 3 critical facets. What is the context? What is the situation of oral health care? How has it historically been viewed across the country? What have we specifically done in San Diego, and what are we learning? And then let's engage in a dialogue around where we need to go from here. And the last panel that I moderated, I joked with the audience that when panels were designed, it must have been with somebody that liked to spend time with their 5 closest friends and ignore that there was an audience or those online. And we didn't do that, and let's not do that now. So I'd like this to be interactive. There's 3 sort of main blocks of topics that we're going through. As I said, the first is the historical perspective of oral health care, and we'll start there. And at the end of that, I'll pause, and what I'd ask is to engage the audience, and if there's questions on that specific topic, let's explore those. We'll then move on to the Gary Mary West Dental Center in San Diego, and we can talk about that specific model, the care we're delivering, the research we're providing. And we can, again, engage with you all, both online and in this room, to really have a meaningful and fruitful discussion. And then finally, let's engage in a conversation of where we need to go from here. And with that in mind, I'll turn it over to the panelists. I'd ask each of them to give a brief introduction, and then we'll get into the dialogue. Thank you. Paul?
Well, good morning. My name is Paul Downey. I'm President and CEO of Serving Seniors. We are delighted that the Gary and Mary West Senior Wellness Center is our flagship facility in San Diego. We actually have a total of 10 sites, but it is our largest and most comprehensive and integrated site. So we're delighted to be part of this team.
Good morning, I'm Karen Becerra. I am a dentist, and I have 20 years of experience working in community clinics and private offices. I am the CEO and dental director of the newly created Gary and Mary West Senior Dental Center.
Good morning, I'm Zia Aga. I'm a medical physician by training and serve as the Chief Medical Officer for West Health. I oversee a lot of the research and program implementation, including some of the work that we are doing with the dental center with Karen and her team. And it's important to see a medical physician talk about oral health, and we'll delve into that a little bit later today, but there's this medical-dental divide that we want to talk about today, and how we really need to share the responsibilities around taking care of the mouth, as does Karen.
Good morning. I'm Bill Scanlon. I'm a consultant with West Health. I'm an economist who's been a health policy analyst for many years, and I've been working sort of with West Health in the last few years. Before that, I was at the General Accounting Office in the Medicare Payment Advisory Commission.
Great. So Paul, I think we'll start with you. So since 1970, you've been leading an organization that really takes a team-based, community-oriented, person-centered approach to aging. Can you talk to us a little bit about what you're doing in San Diego, and perhaps highlight along the journey, how has oral health care surfaced as a need?
Sure. Well, Serving Seniors, for our 47-year history, has focused on seniors in poverty. 85% of our clients live at or below the federal poverty level. Median income is about $850 a month. Most live in single-room occupancy hotels in San Diego, where rents are $675 to $700. So very limited amount of money for other services. Serving Seniors is focused on providing wraparound services. So meals are the core service. We do about 600,000 meals a day. But we have social workers, so we're doing case management. We have nurses doing care management. We provide activities and civic engagement. We're very proud of the fact that we have 30 collaborative partners that we provide space for, who do everything from legal services to mental health services, access to medical care, and we are delighted that the Gary Mary West Senior Dental Center is one of those collaborative partners that has space in the facility. That surfaced as an ongoing issue for many years, and I've been there for 22 years. We were constantly trying to seek grant funding to pay for folks to go to the dentist, because they're in California, Denti-Cal, the Medicaid version in California, is so poor, and for a while didn't even exist. They eliminated it. Seniors had no choices, so we were trying to find grant funds to go get limited care, and we would see seniors who could not eat the food that we were providing. And that was obviously problematic when food is the core service that we're doing, as well as the socialization. And Tim mentioned with Gary and Mary. I was actually with Mary West one day in our dining room when a woman came up, and she was talking like this with her hand over her mouth. She wasn't talking about dental, but she wanted to meet Mary and thank her for the generosity that she had shown serving seniors in the center. And Mary looked at me and she said, "We have to do something about this." And I said, "This is not uncommon to see somebody with no teeth and covering their mouth." So that's what led to it, along with obviously the empirical evidence, seeing that it was such a gap in service.
Great. Paul, you mentioned the vulnerable population, and clearly, from San Diego and comparing that nationally, that's not unique to San Diego. But the learnings around oral health care, as you engage with colleagues and peers that are advancing similar programs across the country, are the observations and needs we're seeing in San Diego unique, or is that something that is starting to surface as a more prominent discussion?
It would be easy if it was unique to San Diego, but it's not. I chair the California Commission on Aging, and we have a oversight role as far as providing guidance to the governor and legislature. And so I'm seeing it up and down the state of California. I'm an ASA board member, and so we're having discussions about this from a national perspective. I guess I would ask, is there anybody in this room who feels that any of your clients has good access to oral health care? I'm seeing no hands go up, and it is a problem. Medicaid obviously is potentially under siege right now, just as it is, and it's not providing adequate dollars to provide services. We know Medicare does not have a dental benefit, so it is a gap, and we see it's a gap not just for low income. It goes up to middle income. Until you have enough money that you can afford, to pay Dr. Becerra's bill if she was in private practice, you're not getting dental care.
That's great. So Karen, as a public health and dental professional, Paul, indicated that the overall tone and pace of the dialogue is increasing. Why is oral health for seniors such an important consideration and area to explore?
Well, for many seniors, number one, seniors every single day are living with a lot of pain, infection. They're living with missing teeth. They're more vulnerable than children are because when their roots become exposed and they take so many medications, the saliva flow in their mouths tend to decrease. With a high carbohydrate diet, it makes them very prone to develop a type of decay that is called root decay. So it comes back to now all of a sudden, they're more prone to develop tooth decay. They have no access to the healthcare services. A whole life of good dental care can go down in a matter of a few years just because they cannot access those services. And what we're noticing is many of them, as Paul mentioned, have the isolation, the social stigma, and this is not only about how important it is for their mouths and their own oral health, but the mouth is not disconnected from the rest of the body. So what is happening in that mouth is an infectious process that it's dealing with inflammation and it's circulating throughout the whole system. So there is a connection with that, and as Tim mentioned, new research is emerging every single day, indicating there's more connections, there's more evidence, therefore there is an even more important reason for us to bring dentistry and oral health care to the front lines, because what I treat when they sit in my dental chair are not boxes here with teeth that I can take out. I take whole human beings, whole patients that have diabetes, blood pressure, lots of issues that I have to be aware of. It's very important in many instances. It will be the dentist, the first person that may notice that a person may be a diabetic. Why? Because of the way the gums look, because of the way the breath smells, because of the symptoms that they are referring when we do the health history review. So it puts us in a unique position. We need to make sure that we bring back that connection. We need to increase that oral health education. We need to make sure that we bring this issue back to the front lines. That is what I am seeing every single day. Seniors that are suffering in pain, seniors that no longer have the confidence to speak, to chew, to function. I'm not talking about aesthetics. I'm not talking about anything fancy. I'm just talking about the simple things in life, like the pleasure you get from eating your food. Imagine if one day you lost that and you have to function without that. Imagine if you're, like Paul mentioned, you're living on a limited income and you have to make hard choices every single day, and you cannot even enjoy the little food that you get because you no longer have the teeth. That is the situation that I see every single day, and that's why I think it's important to bring this back to the forefront.
Great, Karen, there was a lot there. You mentioned that as as we ignore the oral health care needs of seniors, that it can cause a decline in their oral health and in many ways erode any impact or progress that we've made from investments earlier, in their life. Is that a natural outcome? Do we have to see this erosion in oral health, or with the proper preventive and services, oral health care services, can we maintain good oral health care into old age?
I'm glad that you mentioned that, and I'm glad you asked it. Yes, we can, because oral disease is mostly preventable. So when you let it go for years and years and it's unattended, it's just gonna get more complex, more costly, and it's gonna be more painful for the patient. Many seniors or many adults in the whole nation that may not have access may end up in the emergency room seeking a solution to an acute pain that they may have. And the sad part for me is that that problem could be easily solved in a dental office where we have all the resources instead of just putting Band-Aids. It is important for us to be able to address this. How? Through education, prevention, of course, comprehensive dental care. That's important as well, but we have to balance the equation.
Oh, that's great. Zia, Karen mentioned that when we fail to address the oral health care needs, that we can also see erosion from a medical perspective. Can you talk about the link between oral health and medical care and the outcomes that are not possible if you don't think holistically about the broader health, oral and medical, for a senior?
Yeah. So, oral health and medical has been recognized for a long time. We know that poor dentition and periodontal disease have an impact on your diabetes, heart disease, stroke, even acute conditions like aspiration pneumonia. If you think about what is the most common chronic condition in this country, it's not diabetes or hypertension, it's actually periodontal disease. Close to 70% of us have that at some point in our life. If you think about the inflammation and the burden of that disease and what that does to your diabetes and hypertension, it's similar to having a wound on your leg that goes untreated. And we know from both empirical evidence and research that if you take care of somebody's oral health and you do the preventative care and prevent periodontal disease or treat periodontal disease, there are better outcomes. I'll quote some recent data from Cigna. They looked at their 30,000 of their plan members who had one of these 3 chronic conditions that I talked about and had periodontal disease. And by doing targeted treatments to the periodontal disease, they were able to reduce 28% costs for patients with poorly controlled diabetes, that was around $2,000, 25% for people with hypertension, and 30% for those with stroke. So while there is evidence that is being generated, we're still unable to bridge this divide, and that is really important. I think we should discuss that. And some of that is not due to lack of evidence, Tim, but it's in how we have both financed our oral health and medical health, and Bill will allude on that, how we train our doctors and dentists to work in silos and not as teams, and even to the point how healthcare is set up, where most of you, when you go to your dentist, you have to provide your dentist with your medical history and information. And vice versa, when you go to see your medical doctor, you have to tell them what happened on your dental practitioner's office. There is a lack of integration. They don't use similar platforms. Their EHRs don't talk to each other, and they really don't work as a team. And some of the work that we are doing right now in San Diego is trying to advance all 3 of those things. How to build an integrated system, how to share data, so you have one care plan for a patient. How do we think about paying for this? And Bill is going to talk about that. And then how do you look at these meaningful outcomes in totality, not in isolation?
That's great, Zia. You mentioned evidence. Obviously healthcare is not practiced in JAMA, right? It's practiced in the community. So Paul, I guess the question that I'd offer to you, as Zia pointed out, there is evidence, right, that highlights the importance of oral health care. You're operating an organization that has and coordinates services across over 30 different facets. With that evidence, is the sort of the overall awareness and pull for oral health care there, or is there still work to be done to drive that awareness?
I'm not sure that there's a need to drive awareness. I mean, I think the folks that have the dental problems know that they've got it and that they need to get help. I think it's the broader awareness, I think, in the community, in government, and in other, insurance companies to understand that there is this integration. I mean, some of the things that we see as part of what we do is we do something called a comprehensive geriatric assessment. So when somebody comes in, we're looking at all of the issues from, it could be social issues, it's health issues, it's housing issues, it's fiscal issues, all of the things, the wraparound issues that impact whether somebody can sit in Karen's chair or not. And we're finding that people are coming in when they have a toothache, they want to get it taken care of. Somebody has hypertension, they may or may not know that they have it and may not come and seek help. But we're finding when they come in for that toothache that we're now uncovering other things. And I think that is what makes this whole model extraordinarily unique, is this synergy between both sides of the support model, the direct services that Karen is able to provide, and then the wraparound services to deal with everything else. And it could be that somebody is about to be homeless. It could be somebody has untreated diabetes. Somebody could be a victim of elder abuse. These all impact the ability to get good oral health care. And then we're uncovering other health issues that Karen may see when they're sitting in the chair or in the process that we need to connect to a primary care physician and get taken care of.
That's great. So you highlight that there is the awareness, but absent a strong philanthropic environment, it can be challenging to access some of these services. Bill, from a policy perspective, and we'll get into in a moment where we are now, but can you help us understand what we've witnessed to date from the policy perspective? How has the issue of oral health care historically been framed, and perhaps offer what are some of the key areas of focus for policymakers historically?
Sure. I think if you wanted to be kind to policymakers, you might sort of characterize what has happened as benign neglect. That might be kind, but it would be very inaccurate, because I think it goes much more negative than that in terms of some very conscious actions that have actually undermined sort of access to sort of good oral health care, particularly sort of for vulnerable seniors. As Paul mentioned, sort of Medicare does not sort of cover any type of dental services. That was very explicit sort of beginning sort of in 1965. One can maybe defend policymakers then because dental care, along with drugs, along with long-term services and supports, were very different in 1965 than they are today. And so but maybe it's time sort of to think about how do we modernize sort of a program. So what happened in 1965 and what has gone sort of forward since then is we've relied on the Medicaid program to provide the safety net for sort of vulnerable, sort of lower income individuals in terms of access to dental care. And that safety net has proven to be incredibly tattered, particularly sort of for adults sort of and seniors. There's about 20 states that do not cover dental services at all. As Paul mentioned, the coverage of dental services at all is vulnerable. In 2008, when we were in the midst of an economic crisis, we had about 6 states drop sort of their dental coverage because they wanted to balance or needed to balance their budget. I shouldn't say just want, they really need to balance their budget. States operate under constitutional amendments saying they must sort of have sort of balanced budgets. That's a frightening thought given where we are today in terms of thinking about where the fiscal outlook is going to be for states in the immediate future. Even when states cover sort of dental services, there's the issue of what they cover. Do they cover sort of periodontal care, which, as Karen has indicated, may be so key to seniors' sort of health? And the answer is only 20 states. Only 2/3 of those that offer dental coverage at all, only 2/3 of them cover periodontal care. Do they provide sort of fees that are sufficient to attract sort of dentists to actually serve individuals? The reality is fees paid by Medicaid programs vary from 15% of charges to maybe 60% of charges in a couple of states, okay? California, where the dental center is operating, it's 30% of charges roughly. Only 20% of California dentists participate sort of in the Medicaid program. So finding a dentist that will serve you is a particularly difficult issue. And if you happen to be some dental practice that is willing to serve sort of more dental in Medicaid sort of recipients sort of in California, you have to worry about the deficits you're building with each patient that you treat. So it's been this whole history of sort of both, in some respects, ignoring the problem, as well as actually taking actions in order, and primarily for budgetary reasons, to try and or take actions that actually sort of end up restricting sort of the benefit and access to needed services.
Great, thanks, Bill. And I committed in the beginning of this to make this interactive, so here we go. I know there can be some discomfort with the first question. I can assure you that it won't be as much discomfort as I feel if I was standing in the middle of the room and no one had a question. So what I'm going to do is come over here.
Hello, thank you for your presentation. Question, my name's Latia Bozeman. I work at the Division of Diabetes Translation at the Centers for Disease Control and Prevention. You mentioned comprehensive geriatric assessment, and so one of the other organs or organ of the body that also gets neglected is eyes, is the vision health. Does the comprehensive geriatric assessment also look at eye and vision health, and how do you see the two tying together? That's question one. And then my other question is about the shortage of dentists. Even if there was coverage for all of the seniors, what about the dentists and the training for dental professionals?
Well, you ask a good question about the eye care. No, it does not. We cover overall health, and so I think there are some general questions related to absolutely, and we will, and point taken, and we will pass it along. We'll work with our team to address it.
I think the team is looking at using an app that can do vision screening. That's going to be integrated. So the CGA is, the seniors interact with it through an iPad-type device, and there's an opportunity to use a tool that will allow you to do vision screening. But that's a very important point that you raised, especially since we know that eyes are related to diabetes, and hopefully in the future, there's potentially also to make referrals so people can get retinal screenings.
They won't see.
Yeah. Yeah.
It's something we have been working on.
And I think the second part of your question, though, about the lack of dentists, at least I can speak to California. As Karen mentioned, I mean, it's only a fraction of dentists will take Denti-Cal, and there are many counties in California where there are no Denti-Cal dentists, whether it's for older adults, kids, or those persons with disabilities. And that is a problem because the reimbursement, as Bill noted, is about 30%. So dentists don't take it, simply don't take it. I mean, I was in recently for a regular exam. I talked to my dentist. He said he would love to take it, but he can't afford it. And so that's one of the key parts of the shortage.
I want to add a little bit to that. When you have to do so many hours of time trying to bill for procedures that are not covered, that reimburse so little, the small business owner is not only losing how little they get from that reimbursement, it's also losing all that extra time that was spent trying to bill for that. So in many instances, many of my colleagues choose to just do volunteer activities because it's easier. The problem is that even if you open your practice for a patient to come see you, when they have issues with transportation, it's going to be very difficult for them to get to that office. That is something that makes us so unique. We're located in downtown San Diego, where there are lots of bus lines and transportation lines. And thanks to the support of the Gary and Mary West Foundation, we have the opportunity to see those patients that have the Medicaid insurance Denti-Cal in our state, even if the reimbursement is not ideal. Because for us, what we're trying to do is for them to get the right care that they need, regardless of their ability to pay. And where Denti-Cal or Medicaid is dropping the ball, we're making sure that they get the care that they need. So this team that you see here in front is helping me try to figure out a strategy that could not only work for us, but could work in other places, because that is ultimately what we want to be doing, be able to replicate these, prove that there is a model that might work and be able to replicate it in other places, so that in areas where you have dentists coming out of school with a lot of debt, instead of going into corporate dentists, they may start something like this it's something that may work, and we're looking into that. So we're looking forward to the future.
Yeah, I think you also, though, you're raising a bigger question. It's not just a question of the participation by current dentists in terms of Medicaid programs. It's a question as we move forward and as the population sort of demographics change and the demand for services change significantly, is what is the most efficient workforce to meet their needs? And it's going to be a combination sort of dentists and other professionals. We need to determine sort of what are the appropriate services for each type of professional to deliver, how to best train them, so that we actually have services delivered as efficiently as possible to keep the cost down so that they're both affordable to public programs and affordable to individuals.
And I think it's important that the dentists understand older adults during housing training, elder abuse, knowing about multiple chronic conditions, and so it's more than just seeing the patient. You have to understand the environment, the social determinants that impact the patient. So I think that looking at their ability to help the older adult, because as you said, they may be the first ones to notice elder abuse, broken jaw, missing teeth. So I think that's important.
Oh, that's helpful. Thank you.
I understand that cost is a barrier to some of the payment reform changes, or might be perceived as a barrier, and that maybe for a while lack of evidence was. But could you talk specifically about some of the barriers that aren't cost related to expanding coverage? Are there interest groups that would actually oppose expanding, especially at the statewide level, Medicaid?
I haven't encountered opposition to expanding Medicaid. I think where the opposition has occurred is in terms of changing workforce responsibilities, sort of the greater use of sort of other professionals besides sort of dentists, sort of within the delivery of services. I think the issue of cost is one of sort of how one can find a way, if you have limited dollars, to target those dollars effectively. I mean, and that's a challenge. One of the things that we do in public programs sort of routinely is we underinvest in terms of how to design, administer the programs. We have very general rules, and we sort of allow sort of things to occur kind of on almost an ad hoc basis, and the result is that monies are not necessarily spent effectively. That, I think, is one of the challenges we face moving forward in terms of payment reforms.
That's great. We're going to take two more questions before we move on to the next topic area, which is what are we actually doing in San Diego?
Good morning. Thanks for being here today. This is a fantastic topic. I'm so glad to see attention to it. I have a question that I'm not sure if you covered. I was a few minutes late, but I'm interested in particularly the dance between aging women specifically, but also men and bone health, and the osteoinfusions that occur, or the drugs that are given to support bones that actually work opposite from dental health, and very significant impacts that can be had if you're taking those drugs and need to have dental work done. I don't see a lot of conversation about it, yet it's a tremendous issue.
Yeah, so we know that long-term treatment with drugs like alendronate and other bisphosphonates can lead to poor dental health, even in some extreme cases, necrosis of the jaw. I think the important message there is that we have to have better sort of preventative and oral examinations of seniors. Tim mentioned rheumatoid arthritis and the link with rheumatoid arthritis and dental disease. We know that a lot of the drugs, the immunosuppressant drugs like methotrexate and others that we use to treat rheumatoid arthritis, also have negative effects on your teeth, and you need very careful monitoring and treatment. So I think that's a very important point that you're raising, that having the dental profession, one, have knowledge of what are the medical treatments the person is having, and does that put them at risk for poor dental outcomes, is important. And then potentially even financing and paying for more frequent screenings and cleanings for those people who are at risk. Bill mentioned our Medicare policy on dental care. The one change that they have made is that they will pay for a dental examination and treatment for those kidney dialysis patients who are now going to need a transplant. That's the only case where Medicare will pay for dental care, because they know that they're going to pay for a $100,000 kidney transplant, and if you have bad teeth, your transplant will fail.
And to add to that, what we can also do is we dental professionals can educate the physicians, the primary care providers on if you're going to put your patient on a medication that we know is going to have complications, make sure that everything that has to be taken off is taken care of. Just like when you're going to go for your hip replacement and they send those patients to us, it's the same way, so that we can work together and we can, instead of us, each of us being our own silo, just work together for the well-being of that person.
Hi, I'm Di Finlay, and I'm with Iowa Caregivers. And again, I want to thank you for your presentation, very informative. A couple things for Bill. You mentioned the workforce and some of the scope of practice issues that go on. And in Iowa, we have a grant through Delta Dental of Iowa Foundation, and we're focused on the direct care workers. So when you talk about the expansion of this workforce and their ability to provide good oral health, I think this is a sector of the workforce that gets overlooked a lot, the home health aides, the certified nurse aides, because they're the ones that are really doing the day-to-day types of oral health care, and they don't get much in the way of education and training. So this program is being very well received, and I think it also has an economic impact when you think about the prevention side of that and being able to keep people in their own homes longer. If they just know something, like you were saying, just to ask a question, do you have sores in your mouth? Are you able to eat? Simple questions like that as part of that screening, but they're not even aware, of that oral health connection to the total body. And then I also wanted to ask Bill about just the whole return on investment. If you've been able to demonstrate, and we talk about we've talked about it for years, how it makes more sense economically to invest in these kinds of things. Why then is it so hard to change policy at the national level?
Okay. Well, with respect to your first set of comments, I mean, I think you are touching on an issue that goes across healthcare, medical sort of as well as dental, and it's this issue of we have traditionally had a model where we train people that are highly skilled, incredibly sort of smart to do everything, and we think that no one else can do anything. Okay. And we need to think about sort of how do we change that model, because in my view, the reality is if we've got specific tasks, we could actually spend more time training an individual that would be perfectly capable of that task and maybe better at it than someone who we've trained to do everything. So we really need to get to this point where we have a very efficiently trained and optimally designed sort of workforce. Let's go to your second question about this issue of sort of why is it that Zia's mentioned the study that showed sort of cost effectiveness of periodontal care. Okay, why is it that is not sort of the momentum that it takes to sort of get sort of a policy change? We've seen over the last couple of weeks, okay, how important CBO is in terms of sort of policy discussions, okay? And I'm going to tell you sort of what CBO's perspective is likely sort of on this. Yes, it is very, very true that periodontal treatment for people with certain conditions is incredibly cost effective. The issue is how to change policy to get sort of services to those people for whom it would be cost effective without serving a large number of other people. CBO has talked about this before with respect to care coordination. Care coordination can be very effective in terms of avoiding unnecessary services, okay, but only for certain people. If you coordinate, for people that wouldn't have used those extra services, then you've spent money sort of on coordination. This is going to be the barrier that happens if we ever get to a point where we have a serious discussion about adding a dental benefit sort of to Medicare, or sort of in a state government like California, in terms of adding a service. Okay, California has people that are analysts just like CBO, and they're going to come back and say that may be good, but it's going to cost you money. I think what we need to be ready to do is to say, yes, we know it's good, and we're going to tell you why it's good, and we're going to tell you why it's worth the money that we're going to spend on it. Because we shouldn't be doing everything to meet unmet need in order to reduce cost. We should be thinking about how we're meeting the unmet need.
Great, thanks, Bill. So as I outlined in the beginning, we're going to tackle this in three distinct blocks. One is why is this an important discussion, and how has that discussion evolved? The second is, where are we now in San Diego, and what are we doing? And then finally, where do we need to go? So we're going to transition now to what we're doing in San Diego. There will be 2 more opportunities for questions, so if there were additional, just hold them, and we'll re-engage on those in a minute. Karen, you lead an organization in San Diego that's focused on a very vulnerable population and taking oral health care head on. Can you just share the model and what it is we're doing?
Well, through our involvement with Serving Seniors and the Gary and Mary West Senior Wellness Center, we had the opportunity to serve those meals. And like Paul mentioned, despite them being able to access a nutritious meal, they were having so many other issues: cost, transportation, inability to afford the services. So it became very clear that what we were lacking in that center was dental services. I was involved in the local dental society. I knew that even if I wanted to tell them where to send those patients, it would not be easy, just for reasons that I just mentioned, transportation. And so what we decided was, well, why don't we bring healthcare to where those patients or those clients are already coming? And this is a place that it's already trusted, it's well attended, and it just makes logical sense to build an extra facility on the 2nd floor where we can provide those services. Long story short, there we are. We have been open for almost 10 months. The thing that our seniors are, our seniors are more excited about is that to them, they have a whole shop that provides all those services that they need. And now they have dental, they go upstairs, they go through a CGA just because we want to get a good understanding of where those patient or that person's needs are. Do they need help with housing? Have they seen a physician recently? Maybe there's some things that all of this is self-reported. They may not even be aware that there's something else. Maybe, like Paul mentioned, maybe they're homeless and we need to figure out something. I will take care of a person that is homeless, absolutely. I will take them out of pain, but I have to make sure that they also have where to sleep that night, so that if I give them follow-up appointments, they're not competing. Where are they? Am I gonna be able to see the dentist? Am I gonna be able to find where to sleep? So what that CGA does is help us understand from a holistic point of view where those needs are. After they do that, they participate in an oral health education. Why? Because education and prevention are extremely important. And all the span of life is very important, but especially when you're getting older. Why? Because there's things that you may not be aware of. I don't know how many of you knew about root decay, that it's something that many of the seniors that I talk to don't even know about it. And it's so common and advances so fast, we need to educate them so that they can understand why the disease that is happening in their mouths happen and what things can they do. And I will tell you and share with you that what they have said, it's the thing that they are enjoying the most, is having the opportunity for someone to spend that time teaching them and educating them about something that they never knew before. That doesn't mean that they all are gonna be able to make all the changes that we need them to make, but the motivation and the education is there, and that is a good way for them to start. When they finish with that oral health education, we do a basic screening survey. That is sort of our dental triage. It helps us understand who needs to be seen right away, who can wait a little bit longer, because I'll be honest with you, right now we only have 4 chairs, and the amount and the demand for services is so big that we just have to take care of the things that have to be taken care of right away. Then they come to us, and the baseline, because of that oral health education, instead of being all over the place where I have to spend a lot of time educating a patient on what we need to be doing, it's a little more homogeneous, so that we don't have to spend so many time educating them on so many things that they may not know. Their understanding and their desire to participate and be co-owners and partners in their oral health is increased because we're doing the right things. We're spending the time educating them outside our dental chairs. I cannot spend that time educating them when they're sitting in that chair. That it's precious time. Now, what we're noticing from our seniors is tremendous impact in their lives. Many of them have a renewed self-esteem, a renewed sense of dignity. They feel like they have many issues. I won't be able to resolve the housing problem, the limited income problem, but by providing these services, we're giving them an opportunity to feel like they matter, they're not invisible, and they can be active contributors to our society. They can stay healthier and independent, and I'm sorry I'm going so long, but I am very passionate about this part. So that's pretty much what we're doing. We are taking advantage of the fact that we can co-locate the services in a place that it's easy to have access with transportation. We accept a Medicaid benefit that not many other dentists are willing to accept. For those services that are not covered, we have a sliding fee so that financials are not a reason why patients cannot access the care that they need. And we just continue building on the success we're having.
Great. Karen, one of the points that you make as you were speaking is that as we characterize the needs of an individual, it's not just a simple linear process. There are multiple interactions where you look holistically around, really, what are the key needs, right, and jobs to be done. Paul, as you think about, sort of making the most of that insight and coordinating the services that you provide, how are you ensuring that we're not having missed opportunity?
Well, and I think that's really important. So what Karen was talking about, when they're in the dental chair, she can't deal with their housing issues, their food issues, their other issues, but serving seniors can. That's what we do. My staff can't fill a tooth, but we can find a homeless person housing. And I think that is key, is that we're looking at it holistically. So right now, we don't have on-site medical, but we have access to that. So essentially, there is a full safety net in one place, and I think that is the key. What we do at Serving Seniors, and we have for our 47-year history, is the concept of a warm handoff. So if somebody comes in to see a social worker, and the social worker identifies that, there may be a mental health issue here, our social worker, will almost quite literally, at that moment, take them and have them meet with a psychiatric nurse who comes from Sharp Healthcare, one of our collaborative partners. If it turns out, there's a legal issue, the psych nurse will take them to see one of our collaborative partners from Elder Law to see an attorney. If through the CGA process we identify, there's a major oral health issue, our senior care navigator will quite literally take them by the hand and make sure that they get an appointment to see Karen as soon as possible. So we know with our clients, because of the poverty, because we do have a significant number that are homeless, that if they came in and saw the social worker and we said, I can have you see the psychiatric nurse a week from Thursday at 3 o'clock, here's your appointment card, we'll see you then, not happening. But if you make it easy and warm handoffs, and it's the same concept with dental, is we make sure that they get to where they need to be.
No, that's great, Paul. Karen pointed to the structure, and structure relates to outcomes. We've put the dental center in the community center to cause this collision. And Paul, you've just alluded to some of the behavior, right, these warm handoffs. Can you comment also on some of the other things and steps we've taken to, enable those coordinated outcomes, how we're leveraging data to do that?
Right. Well, I think that's the key. And so through this whole process, we're collecting the data. So, and we do this on everything that we do, whether it's somebody getting a meal, taking an exercise class, or seeing the dental. And so we are doing a detailed study. We have a physician, Dr. Eli Arnoff Spencer, who is leading that effort for us to do a detailed study of the data that we are collecting. And it gets to sort of, Bill's point about being able to sort of prove that this is a model that should be replicated and can be sustained in some way, and finding a way to come up with a funding mechanism. And I think that is the key part of it, is leveraging that to influence policy. And so, the big one will be figuring out a major funding stream, but even on a small basis, we're working in California with a couple of legislators on just some smaller fixes to Denti-Cal that will make Karen's life easier, and hopefully maybe at least increase some of the reimbursement so that we won't be losing as much money on every patient. Because I think the reality is right now this model works, because of the philanthropy and generosity of Gary and Mary West. And so we're hopefully proving that it's something that can be replicated, but absent that support, this wouldn't work.
Great. Paul, you mentioned funding as a barrier. As you think about access to the healthcare and supportive services outside of San Diego, thinking about other communities and efforts that are underway, what are some of the other barriers that we've overcome yet others are facing as it relates to enabling this access?
Well, I mean, I think the key is collaboration, is being willing to work with multiple partners. I think looking at bringing services under one roof. Karen mentioned that the Gary and Mary West Senior Wellness Center is strategically located. There are 3 senior high-rises within 2 blocks. It is on major transit routes, so it is easy to get to for people, whether they live in the immediate neighborhood or live in the surrounding areas. So as you look at ways to do this, is making sure you are strategic about where you're locating services. One of the things that Serving Seniors did is when we built the Wellness Center, and it was part of the vision that we initially shared with Gary and Mary when we were talking to them about this, was that we actually overbuilt space, because it's actually relatively inexpensive to overbuild space. And what we do with the collaborative partners that I mentioned, and that's why I say collaboration is so key, is we provide them space for free. In return, they provide free service from the client perspective. You know, if they can bill Medicaid, great. If they can bill a grant, great. But from the client's perspective, it's free. And what we ask them to do is to share their data for the research that we're doing, and they have to be part of our interdisciplinary team. So I think for many nonprofits, it's getting past the barrier of wanting to truly collaborate. In the nonprofit world, there is forced collaboration because a funder will say you've got to collaborate, but I would encourage nonprofit organizations and others to embrace the notion of collaboration, which at the heart of it is what we have with the dental center.
Another one of the barriers that we are removing is the cultural barrier. We are able to speak to our patients in their language they speak. We have assistants, we have team members that speak other languages, Mandarin, Spanish, the main languages that are spoken. That's very important because it makes the person feel more confident when they can go to a healthcare provider and explain to them what is happening and understand from them in their own language what needs to be done. Geographical barriers, we're removing them because we are making that transportation no longer an issue, at least for our population. Financial, we're making sure that they're not able to, that they don't access the services because financials are a barrier. And logistics, as Paul mentioned, we work together. We make sure that we share information so that we're not working independently. For us, that senior patient, I may have an obligation to my patient, but there is some information that is shared in that building so that the social worker, the case manager, the hygienist knows what's happening to that person. They're coming for an appointment. They need, they're not doing that well this week. They need to have their meals delivered at home. So that collaboration, that multidisciplinary approach is part of what makes us so unique, and it's part of the recipe that we're building.
Oh, that's great. You know, when one of the themes that is emerging here, this concept of collaboration, the variability that exists amongst person-centered goals for what's important to the individual, and even controlling the process, right? They're dynamic. We're thinking about it holistically. It can't just be rules-based. Zia, from a health science research perspective, can you comment on why, one, it's important to have them co-located? What's the power of the co-location? But also, from a research perspective, what are some of the considerations that need to be addressed given sort of the intrinsic variability that exists in these models?
So if you look at, and I'm going to use the example of the CGA, which is a very important, I would say, assessment tool, but also a care delivery tool. If you look at the research that's been done on CGAs in the past, most of it has happened in integrated places like a hospital or a clinic, not too much in the community. And as we embarked on our journey with the Gary and Mary West Senior Center and the Dental Center, implementing the CGA process in that community setting really involves changing the culture and the environment. It's not about just having a questionnaire, here it is, 45 items, go do it. And what do we have to change? You have to come up with new workflows. You have to come up with new ways of connecting the dots. You have to ensure that you close the loop and that actions and activities are conducted. A recent study that is looking at data from CGS, and by the way, CGS have been shown to reduce mortality up to 30%. They've been shown to reduce hospital admissions, nursing home stays, all kinds of favorable outcomes. A large meta-analysis recently done showed that there were some CGAs that were better than others. And the ones that they found, the implementations of these comprehensive geriatric assessment programs that were better suited to provide the right outcomes were ones that were in an integrated setting, ones that actually led to implementation changes, not just referrals and consultations. So the idea of the warm handoff versus the cold handoff, so that not only did you find a problem, you were able to act on it. And then those that we're able to then follow up and track those changes over time. And I think our center is really doing all three of those things, which makes it both unique and powerful. I do want to point out that there are learnings that are going to come out of this research and this work that do have the opportunity to disseminate to other settings. Yep. While co-location is so critical for us and has been so important, there are other models that can use a comprehensive approach without being under one roof and still get benefit. So don't misunderstand us by thinking that you have to have everything under one roof. I think what's important is that you provide the necessary linkages to connect the dots so that the senior, from his perspective, is getting all the services that they need, and then there is follow-up and care provided.
Great. Yeah, when one thinks about research, it's easy to go to the outcomes, and when you talk about outcomes, at least many automatically jump to clinical outcomes. But when we think about research, and to the point Paul made in terms of warm handoffs, there's the research that validates operational models, right? What are the practices that work and the practices that don't work? How do you think about reducing variability, right, from an operational perspective? And I think it would be helpful if you could comment to the group on how you think through the operational side of that research and validating some of those models with the work in San Diego.
Yeah. So, operations, and I touched upon this a little bit, when we think about this process, it was, the first goal of our research study was to really implement this new process, which started by studying the process that were existing, looking at information flows, looking at people's roles and responsibilities and workflows, and then working with the team using a participatory model to develop a new process with Karen's team, with Paul's team, and then implement that model and study it along the way. So, sort of typical quality improvement or implementation science framework. As you think about some of the outcomes that we are tracking that are meaningful, they can go anywhere from even engaging with the people who are involved in this work and getting their participation and ownership of the work, to better workflows, to better handoffs. For instance, we're tracking data on how many people received the CGA, what's the completion rate, and we're finding in our studies north of 90% completion rate for an instrument that can take almost an hour to complete with a senior. That in a typical healthcare setting is unheard of, and I think part of the reason we're able to do that is because of the location, but also because the team, the people who are doing this work really believe in it, and they've helped create it. I think it's important that they take ownership of it. Other examples of favorable process outcomes are the types of patients we are identifying and what we are doing with them. So we identified, for instance, 70% of the seniors, and this is a little bit of a biased sample in the initial group, needed oral health care. So they had unmet oral health needs. And all of them have, so 350 of the 500 CGAs, the data that I'm quoting, have now been either seen or have gone through Karen's clinic and getting oral services. 25% needed mental health services, and they were connected to the mental health social worker, and where sort of a warm handoff was done. So I think while there is tremendous variability, Tim, it's important that if you are going to embark on this journey, it's not just about a tool. You really have to consider a number of other facets that involve process change management, even to the point of how your IT systems talk to each other. We have a Open Dental, which is the dental medical record that Karen's team uses. We have Efforts to Outcomes, which is a data set that Paul's team uses. The researcher who implemented the CGA uses yet another tool. And we've made efforts to make sure that data flows seamlessly across these three platforms. But also we're trying to link into our health information exchange in San Diego. San Diego has a very successful HIE, and we're linking to the HIE to get clinical feeds around admissions and discharges and transfers, which are so important to really understand what's happening to the seniors once they're out of our center.
Great. We've talked about why oral health care is important. We're about to wrap up the discussion on what's being done in San Diego, and we'll turn to questions in a moment. What I want to do is turn to Bill. When I think about research, I think about evidence. When I think about evidence, we've talked about in the past evidence of problems and evidence of solutions for those problems. Can you talk about how the research and the model can inform that evidence creation, and how might it be used?
Well, as I think, as you indicated and as I indicated before, sort of we are sort of very reliant, sort of in policy, on sort of having evidence, and it's the CBOs of the world that sort of will be sort of the filters for that evidence, and I think it's very critical that we get sort of the evidence kind of in their hands as well as in the hands of sort of the policymakers. And the policymakers' perspective could be a little bit different than the CBOs because it could take into account the value of the services as well as the sort of the costs sort of the services. And to give you an example kind of how important this can be, there was a webinar that Academy Health put on a few weeks ago on oral health care. And one of the participants sort of in this webinar was one of the principal staffers that wrote the Affordable Care Act. And a question was asked was, why didn't you do anything about adult dental care in the Affordable Care Act? And if you wanted to sum up his answer, it was essentially no one asked. Okay? And that, I think, is the reality, is that what we need to do is we need to assemble the evidence and make sure that it's disseminated into the hands where it will matter in terms of that they understand the situation and that they understand sort of the options and they can make a much more informed choice.
Great, thanks, Bill.
Hi, I'm Mary O'Donnell from the Retirement Research Foundation. Thank you so much for the incredible work that you're doing and sharing your lessons learned with the rest of us. Being in a grant-making organization, I think a lot about sustainability and models that we can replicate and all those buzzwords that drive everybody else crazy. And I am very cognizant of the fact that what you all have been able to achieve in San Diego is absolutely incredible. Using your words, probably the model wouldn't work without the incredible philanthropic support from the Gary and Mary West Foundation, and many of us really admire their leadership on this topic. So one of the things that I'm struggling with is what, if kind of we think of the co-location approach that you've been able to successfully implement in San Diego as being perhaps the gold star that we all could strive toward, what might be some of the other models that perhaps could be a bit lower hanging fruit with smaller price tags that might at least allow us to advance the issue while we try to rally in ways that can solve the overarching policy reimbursement challenge and kind of fill the gaps in communities that don't have the benefit of your philanthropic support. I don't know who wants to take that.
Sort of start with part of it, and others may want to jump in. I mean, I think what we've tried to do is take that comprehensive approach. I mean, that's been Serving Seniors model for most of our history, with fortunately adding the dental component into the array of services we're able to offer in the collaboration with the dental center. But for me, I think the key are meals. That actually is the place to start. In some respects, adding these other services solves two problems. Congregate meal service is actually declining in many places. Home delivered meals are going up. Congregate meals tend to be going down, and that's mainly because I think the idea of going to the church basement to just get a meal and that's it and no other services is not appealing. But if you provide a center that has a lot of activities, fun activities, as well as services, the meals become important. So that becomes the draw. And so I would argue that looking at the senior center as the place to start, and you may not be able to have all of the bells and whistles, but I think starting there and adding in the services as you can, and again, the notion of leveraging capital costs, because when we built the wellness center, total acquisition rehab of the facility was $8 million. In 2016, the value of the collaborative services to serving seniors, and this doesn't count dental, just everything else other than dental was $1.2 million, and if we add the value of the dental, it's going to be over $2 million worth of leveraged services. So you can see in 1 year, 25% of the original investment 7 years ago gets paid back and keeps getting paid back every year. So the notion of building space, getting other organizations to come in, give it to them for free, integrate them in, is a relatively cost-effective way to do it. And I would add, the data so that you are able to show the ROI, that by making that investment, something good has happened.
I would add that we were very fortunate in San Diego to have the support from the Gary Mary West Foundation, but there are also simpler ways in which other professionals in other locations can start. Simple oral health education are really well attended. We can train different kind of providers, not only oral health professionals, but providers in long-term care facilities, providers in hospitals. Just try to increase that level of education. It's something that can be done easily. And like I said, from our experiences, seniors themselves are saying they never had the opportunity to learn what was happening. So it's important to empower the person and provide that level of education. There's so many other organizations that are working on this so that we can bring up some level of coverage that is more than just what a local person can do. All the technologies that we have nowadays make it a lot easier for us. We can never leave behind the prevention and educational part from what we're doing, because if we do that, in my own words, we'll be doomed to drilling and filling forever, because that's what's going to happen. Unless you educate the person and explain to them, it's just going to be very difficult to sustain. So the more you invest in education, the more you invest on cost-effectively prevention measurements, the cheaper it's going to be able to start something without having to have that major dollar tag on it.
Yeah, I think, Karen, that's a really important point you mentioned. There's a quote in an article that I was reading that you cannot treat your way out of this problem. It really is about prevention. Yeah. And I think when you think about prevention, there are opportunities to have those services co-located in different settings. There's a 6-point plan that came out after the Surgeon General's report on oral health and the hidden epidemic, working with HRSA to develop strategies for integrating some of the oral health screenings within primary care and other settings. So I think those things can be implemented without a tremendous amount of cost outlay or even training and developing a new workforce. I think the learnings around having a comprehensive approach and looking at the whole person approach in terms of doing a full geriatric assessment is really important. Anybody who's practicing geriatric dentistry needs to understand that it's not just about taking care of the teeth. You have to also worry about their diabetes and their social situation and where they live. And those types of metrics and tools can be integrated in communities that are providing care to seniors, vulnerable seniors. Education and even caregiver support, something that you talked about, both formal and informal caregiver support has tremendous ROI in terms of treating and preventing oral health outcomes. Traditionally, we've seen data that those seniors who live in community-based settings, like assisted living or nursing home, have better oral health and outcomes because there the caregivers are able to do the flossing and cleaning and help them do it, which seniors themselves cannot do. But seniors at home may not be able to have access to that and take care. So just by simply educating their caregiver and providing them with the necessary tools and supports. I wish Karen had brought her tennis balls and toothbrush that she shows off, which really is a simple tool that allows a senior who has bad arthritis to hold a toothbrush to brush their teeth. So really simple things like that can have positive outcomes that don't require changing the whole healthcare system.
Yeah, I agree that, what we have in San Diego here is an ideal in terms of real-time sort of physical integration, et cetera. But I think as we think about how we can expand sort of what the lessons from this, We have to think about where are the resources out there now. And to be honest, they're in the medical side of the world, okay? And even though, if we had a meeting today here in this room focused on primary care, we would hear about the shortage of primary care and how primary care sort of practices are overworked, okay? I think we need to introduce into that discussion, how do we reorient sort of what primary care practices do as well as what dental practices do, so there's more recognition across the two. So, and that kind of integration, even though it will not be anywhere close to sort of what we have here, will still be beneficial. One of the realities we discovered in serving the seniors at the dental center is that 85% of them have had contact with their primary care physician in the last year, whereas 20% of them haven't seen a dentist in 5 years. So there's a very big gulf between sort of your access to a dental professional versus your access to a medical professional. Let us make the best use of those medical professionals in terms of oral health.
Great point, Bill. We have a question from Cindy.
Thank you. My question kind of integrates the last two. I'm involved with a program in Philadelphia that serves thousands of people a day, and it is mainly a large senior center. We have had on-site dental care and medical care for quite a long time. The dental care has grown incredibly, and it's very exciting that we have a bit of philanthropic dollars to be able to create a brand new wellness center and sort of take this to the next step. And interestingly, your comments were related to what I was thinking about. Our biggest obstacle is the medical profession. They're used to and have been used to just doing their primary care and have been difficult to kind of bring in together and be champions for this collaborative approach. The dental folks have been our champions in the system that we've been working in. I guess I'm looking for some assistance about how to bring this conversation to a better place so we can be more successful in doing something more collaboratively. The second question I have for you is, how do you afford this assessment process where we're looking for ways to contract and find a way to have that, maybe contract through healthcare? We're having some difficulty kind of articulating that. So those are my two. You could help me a lot.
Do you want me to take the second question first, and I'll defer
why don't you start?
on the first? So on the second question, so Serving Seniors, we're a nonprofit organization, so we receive funding from a number of sources. We're fortunate that the Gary and Mary West Foundation is specifically helping on the comprehensive geriatric assessment process in terms of helping with funding. But then we use other sources, so to pay for our social workers and our other staff, we're raising money. As well as we're an Older Americans Act nutrition program. So from Serving Seniors' perspective, we cobble together a whole series of funding sources in order to do this. I've been fortunate that my board has been very supportive of us reaching as far as we can to provide comprehensive services regardless of whether there's a government funding source or not, and so we constantly look for philanthropic support to be able to do that, as well as some earned income opportunities that we're generating. I'll leave the harder questions to Zia.
I think you bring a really important point, and I mentioned this earlier. I think it starts with how we train our professionals. There's some really interesting work happening in Boston where they took medical students and nurses who were in training, sort of the medical group, from one academic institution, and then matched them up with dental students, and they trained them together over the next year or so, and they had them sort of rotate through each other's sites and learn about oral health and learn about medical health. And what they found was that this group of doctors and nurses and dentists were able to collaborate in a much different fashion. They also were able to cross-train each other in understanding these problems. As a primary care physician, honestly, we don't pay any attention, and we're not trained to pay any attention to the mouth. We will look for throat cancer and we'll look at your tonsils, but we'll go right past your teeth. If we see a problem, we will refer it out. So I think it starts with changing how we train people. I think on the other end, we also have to have certain quality measures or performance measures that hold primary care accountable to the oral health issues. The U.S. Preventive Task Force has a long list of preventative measures that it recommends, including colon cancer screening, skin cancer screening, mental health screenings, and all of those are primarily conducted by the primary care workforce, whether it's the nurse or doctor. but there isn't one around oral health for seniors. There are for children, and pediatricians do a fairly good job of managing that. So I think we need to sort of advance the conversation around how do we integrate primary care into this problem. I agree with Bill that there's a great opportunity given that most seniors are accessing some level of primary care in our setting, 80% or more. And it can start by simple screenings. So the type of screening tools we are using can be easily implemented in a primary care office setting by a nurse or an MA or an LVN, and then followed up with education and referrals.
Yeah, and not to be the cynical economist, but to follow up on what Zia was saying, I mean, I think absolutely training sort of the next sort of cohort of professionals in the right way will be an incredible sort of benefit. But if we can find the measures that really capture sort of things of value, and then we can create sort of policies that reward them. What we've observed in the past is when we put rewards out there, the response is instantaneous. So we just have to think about sort of what are the important measures that we really want to reward.
Great, thanks, Bill.
Hi, I'm Rebecca John from Chicago. I'm a resident service coordinator in affordable housing. And I'm really curious about the preventative oral health education program that you have set up. And I'm just seeing a lot of synergy between the program that I attended yesterday on family health care providers and primary care providers among family members. And so I'm wondering, and also having worn the hat of being a manager of a homemaker program, and listening to the woman from Iowa, and how widely are you sharing your educational model? How easy is it to replicate? Is it curriculum that you're willing to share that can be shared with a dental office to come in to provide that? Is it something that a layperson can do? If you could just talk a little bit more about that.
So we started by first making it separate. It happens outside the chairs because we wanted to make sure that later on it could be done anywhere else. Right now it has to happen within the building, but our plan was to be able to go to other places, have other type of providers being able to administer that type of curriculum. We are collaborating with other organizations. We created our own. It came out of the results of a series of focus groups where we asked our own seniors what was it that they really wanted to learn about. Many of them had told us anecdotally, well, I'm too old to learn, I already know it all. Well, we asked more than 400 before we started these to try to understand what were the topics that do matter, and that's how we created our content. Like I said, we have collaborations. We're not the only ones doing this. Oral Health America is doing a lot of online oral health education. So I think as we continue moving forward, that's going to be the route that we're going to have to move so that we can train anyone, anywhere, so that they can provide this level of training. It's not that complex, but when you don't know what to teach, how to do it, it makes it much harder. It would be very hard for me in the beginning to have to move my own hygienist from one of the chairs to provide that training. I was able, and that kind of answers the previous question, I was able to engage dental hygienist volunteers, dentists that volunteer their time and come and teach. When you're not expecting that on every single day, it's much easier. Perhaps just like I tell them, give me 6 or 3 days out of the whole year. When I have several participants, then I can have something that is regular and that is staffed by volunteers. That's one way of doing it. And of course, we're gonna continue evolving so that we can make sure that this is something that doesn't have to be unique to us and that we can replicate and share with others so that we can increase the participation in the oral health education that we provide.
That's great. When we think about where we go from here, one facet is how we think about scaling and disseminating those learnings. But there's been an undertone of policy and funding that's been part of this discussion. And Bill, I'll turn to you. It is an uncertain policy environment right now. And could you frame some of the potential outcomes for us? And within those outcomes, what might be examples of wins?
It is an uncertain environment, and even if it turns out that it remains uncertain, uncertainty is not a good thing. I mean, because I think that we face a situation now that's very different than we faced when we started the dental center. We were thinking when we started the dental center of how do you improve sort of Medicaid dental coverage sort of for adults in California. And we're now facing sort of, if you're a legislator in California, you're facing the prospect that the largest Medicaid expansion sort of in the country under the Affordable Care Act may be defunded. You're faced with sort of the idea of living under a per capita cap sort of for the future. And so sort of where does adult dental care sort of fit sort of in that set of situations? I think that in terms of an absolute success at a minimum would be to try and preserve the benefit that we have right now. A second, even greater success would be to think about, is there any way to have some incremental funding targeted in a way that's most sort of effective in terms of meeting sort of needs. And there are various ways I think that we could be defining sort of the greatest need. It could be sort of in terms of particular patients' types of needs. It could be that those needs are associated with the fact that they have very serious conditions or they're very hard to treat, and therefore they have much greater access problems than sort of an ordinary patient. I mean, Karen can tell you sort of graphic examples of sort of that it's very different to go to a dentist when you're a senior with multiple chronic conditions as opposed to you and I sort of visit the dentist. It's kind of a routine thing to get in the chair, get treated, and sort of go on. That's not the experience that they have. We also need to be thinking about sort of the fact that vulnerable seniors, low-income seniors, are very concentrated in certain areas of communities. And to have accessible dentists, those dentists are going to have sort of a disproportionate share of their patients coming from sort of the Medicaid program. We have to think about how do we protect them so they remain providers of dental care to sort of Medicaid sort of eligible seniors. These are the kinds of things I think that we should focus on in terms of are they going to be feasible to do. Those would be the kinds of things I would think if we're successful, we might be able to sort of to accomplish. The notion we started with a year ago in terms of expanding sort of say coverage for different services, those are a bit on the back burner at this point. Let's hope that they are never sort of out of mind, because if we can demonstrate sort of the need and benefit, maybe we will reach a point where there will be enough priority given to these kinds of services that they will get sort of better attention.
That's great. It's important to understand where you've been, where you are, but really what we're here for is where are we going. And Karen, I'd like to ask you, for those in the room and those joining us via the live stream, if there was one thing you could encourage them to do to get involved to help advance senior health care across the country, what would it be?
Well, I would encourage everyone to speak up. The longer we stay quiet, the longer we don't give oral health the importance it deserves, the longer it's going to take for all of us to realize that that's something that is going to happen. Unfortunately, the mouth has been disconnected from the whole body for far too long. This is the time for us to bring that up to the front lines. We need to, wherever you work, wherever you all go to your dentist, you all have clients that you serve, you all go to hospitals, let's make sure we keep this conversation fresh. I would say we need to make sure that with the work that we all are doing, we're not the only ones working on geriatric patients, but with the work that we're doing, we're going to be able to demonstrate how what we're doing impacts their health. If we want to continue this conversation, we need to bring the attention to where it needs to be. That is, dental cannot be disconnected from medical. Dental should not be something optional. Dental should not be something that if you can afford, then you're going to be okay. The majority of baby boomers may not know that they don't have a Medicare coverage when they turn 65. You may know it because you work in an environment where that's pretty common to you, but where I go to, and with the younger population, they're not aware of that. We all are getting older every single day, so this is not unique to the patients that we serve. This is unique to all of us because in one way or another, it's going to impact our parents, our grandparents, or if not them, ourselves. So we have to bring the attention this deserves.
Great, thank you. I'd like to introduce Bob Blancata, Board Chair of the American Society on Aging, to say a few words to conclude the session. But first, I'd ask you to join me in thanking our panelists. I think this has been a great discussion. Bob, thank you.
Good morning. Well, this has been a great session, I can tell. You're all still in your seats, and you look like you've been attentive, which is great. And it's my pleasure to sort of close this by saying a couple things. First of all, I want to thank the Gary and Mary West Foundation for supporting and organizing this session, but their larger support of ASA in 2016 in many different facets. You know, I've known and followed the work of West over their entire 10-year and, couple months history. They have been cutting edge on so many issues impacting older adults. They do what I call purposeful philanthropy, which is always focused on outcomes and improvements. Today, the spotlight is on their groundbreaking work in integrating dental health, oral health, and wellness to improve the health of older adults. And their work has had impacts on the local, state, and national level, including a first-time reference to oral health in the Older Americans Act. I am especially pleased that our newest board member, Paul Downey, was here and offered his wonderful story that is something that has national implications. But I want to close by saluting Shirley Lyford, who the president and chief executive of West Health and the Gary and Mary West Foundation. This is a leader. This is a woman who's an impact player. That's what I call people like you in Washington, an impact player with vision, compassion, a deep regard for having older adults age successfully. Her work has and will continue to make a real difference, and we thank you for that, and we thank all of you for coming to ASA and being at the session, and we look forward to seeing you in the general session in about a half an hour. So thank you very much. Thank you.
And Bob, thank you for your leadership and all the work you do to advance aging across the country.